healthy skepticism about this monkeypox outbreak. And the reason why we did is we had received a word that a group called NTI held a biosecurity conference in Munich in March of 2021, where they predicted a monkeypox outbreak, and they proposed a timeline, and that the release was going to be May 15th of 2022, just 1 week ahead of the World Health Organization deliberations over the treaty and the initiative to unify pandemic response across the country. So, that point alone, the fact that it was there was a tabletop exercise to basically plan a monkeypox media event in March of 2021. And then it comes out almost to the day in May of 22, made us skeptical. The next thing that made me skeptical is that the pictures that were being shown in the media, some of them looked quite old. Some of them looked like they were 50 years old. So someone on our team today found at least 4 media releases that were fake. They were just using old pictures from an old monkeypox outbreak. So I want to let you know that part of what you're seeing isn't completely real. Now, let me get to the slides. Carl Simpson and colleagues held a symposium in the UK in 2019, a conference, and it was titled Human Monkeypox, After 40 Years, an Unintended Consequence of Smallpox Eradication. They reviewed 40 years of data, and there have been monkeypox outbreaks. It was first described in monkeys in 1958, the first case in humans in the 1970s. United States, there was a well-described outbreak in 2003, 70 cases, where pets were intermingled. It turned out that pet prairie dogs were intermingled with giant pouch rats from the Congo Basin. That's where monkeypox emanates from. Monkeypox is an orthopox virus closely related to smallpox, cowpox, camelpox, and the other pox viruses in there. It's a double-stranded DNA virus. So they outline there's been 40 years of this, and they suggest that most of the cases occur in young male adults from the Congo region, maybe some handling animals. The case fatality rate in some of the press releases have said 30% or 10%. They had reported here a 5 to 6% rate, but almost all the deaths occur within HIV positive young men. Now, people who have been vaccinated against smallpox prior to 1980, United States had stopped in 1972, they have a 5-fold lower risk. They have protection against monkeypox because they've received the smallpox virus. So this is an important teaching point when your patients ask. I have patients today ask me about monkeypox. This report from Oji Ina and colleagues from the Niger Delta University Teaching Hospital in Bayelsa State, Nigeria, reported on 18 cases that were confirmed. All survived with supportive care, except for one suicide. And here you can see that the most common manifestation is the pathognomonic pustular vesicular skin rash that affects the palms of the hands, the arms, the legs, face, and trunk. Then fever, then itching, then malaise, and then lymphadenopathy. It's spread by saliva in close facial contact or by touching the pustules. Okay, by touching the pustules. Of note, the viral infection has a specific therapy called tecovirimat, which inhibits the ability of the virus to interact with the cell membrane. So tecovirimat, also known as TPOXX, is an oral drug taken twice a day, and it was FDA approved in 2018. And 3 days ago, the U.S. FDA approved IV Tecovirimat. There's also a monkeypox vaccine, a live attenuated vaccine by a company called Syneos. And of interest, Dr. Carl Simpson is a consultant to Syneos. That was one of Syneos. Looks like they paid for this conference. The live attenuated vaccine company, Syneos, just received a contract from the U.S. government for 13 million doses of monkeypox vaccine as a pandemic response measure. Turns out that there was a case of monkeypox right here in Dallas, Texas. I bet John didn't even know about this. This paper was reported in the MMWR in April of 8th, 2022 by Dr. Agam Rao. And this was from the July 21st monkeypox response team. So all these authors are on a monkeypox response team. That was last year. That was last summer. And this is a patient who traveled, went at DFW, and because of his prolific contact with other people, came in contact with dozens and dozens of people. And so in this paper in MMWR, they did contract tracing of everyone. I think they ended up looking at a couple hundred people. And it turns out that despite all his contacts, he did not transmit the virus to a single person. He was admitted to the hospital as shown here. So he starts out in Lagos, Nigeria, and you can see he lands at DFW airport. And then on July 13th, he's put in the hospital. They kept him in the hospital for a month. I think probably because they didn't know what else to do with him. We knew that the paper from Nigeria, people can be treated at home, but they kept him in the hospital and they treated him with Tecovirimat, the oral drug for the course of his orthopox virus infection. But the point of this MMWR report is that not a single patient got the virus from him. And he was a flagrant case of monkeypox right before our very eyes here in Dallas, Texas. So I can tell you what we have is we have a situation where it looks like there is an intentional fear campaign. There are probably almost certainly falsified reports. The R naught value is less than 1 for this. That means that just like his R naught value is way less than 1. You don't spread it to other people. People are contagious when they're acutely symptomatic. It's treatable with an oral and IV drug. And those who are older have protection because they've already had the smallpox. And a lot of us are in that age range, over 50. We've already had the smallpox vaccine. And so that's an update on the monkeypox. Anybody have any monkeypox questions while we're on?
There's one thing I would add to that, if I may. I don't know if anyone on the call has spent time in Africa, but one of the things you notice when you're in Africa is that you'll have a lot of children sleeping in the same hut. So if one little boy is playing with an animal that is contaminated with monkeypox, and then he goes home to his hut and he sleeps with his siblings, this close contact, sharing the same bedding and so forth, is a very efficient vector for spreading this kind of close contact thing. I think a lot of it is happening in shared bedding. Obviously, that's different in a more industrialized setting, where I think the circumstances are quite different for the way this sort of thing would spread.
I'm glad you mentioned that. You can see there highlighted. They went to his home or the place he was staying in Dallas, and they did large-scale decontamination. Some people may ask, how can you do that? There's a way of decontaminating viruses. It's using what's called HOCl, or hypochlorous acid. And the product that you can do to do this is what's called the Genesis fogger. And it's a way of putting this mixture in a fogger and literally setting up in a room, and you can decontaminate a room that way. And so the Genesis fogger, it's a commercial product. You can buy it. Actually, it's been used to decontaminate rooms of people with SARS-CoV-2. It kills SARS-CoV-2 virus and probably this. It also kills various fungal spores, etc. Okay, other questions from the audience on monkeypox. Has anybody here on the line seen an actual case and just can give us a case description?
No, but I do have a question.
Okay.
Because I heard the rumor, I don't know if it's true, you guys are probably way more up on this, that the Wuhan labs have already performed gain of function studies on the monkeypox.
Yeah, I don't know. I can't.
I don't either, but that's what I was told.
I can't.
So,
but
I
you
don't
know
know.
what? But John, you're being suspicious, and
Yeah.
that's what John Leake says now. At this point in time, we have a right, and we have, I think, an obligation to society to be suspicious. We should be skeptics. We should be skeptics of the information coming in, and then we should do what I've done. I went to the literature to become prepared in case I do see a case. But I've mentioned to a few people, I need to see a case. I need to see a case as a doctor for me to really understand what this is. I have not seen a case of monkeypox in my life. When I was a kid and as a young doctor, I've seen plenty of chickenpox, but I've never seen monkeypox or smallpox. Anybody here in their career see a case of any of the other pox viruses outside of chickenpox?
Yes, I have seen smallpox when I was a resident in India.
Dr. Patel, when people get really sick with smallpox or potentially have fatal or near fatal complications, what makes them so sick?
I think that their environment has to be the kids, those who were moved to a special place where they were keeping all the smallpox patients, but they were like on a hill and they were being treated specifically by their parents. They had a better outcome than any of the paramedical staff taking care of that, improving their nutrition, giving them certain vitamins. And so I think that improved. But what bothers me about monkeypox is that a year ago, they made that monkeypox may become a pandemic or may become an endemic, whatever. And then we are seeing it 1 year later. It is like a Bill Gates telling that we are going to have a pandemic, and then pandemic comes, and then we are going to have a monkeypox, and then we have a monkeypox. What is there that they know ahead of time that we don't know?
Their agenda.
Yeah.
I right their agenda, but where do they bring that
Well,
if it isn't real, where do they bring that virus and how the virus gets into circulation? I mean, what John was talking about, I mean, there has to be, like you said, propaganda or conspiracy theory or whatever else. But I mean, it just, and when you talk to a Harvard infectious disease, oh, well, we have to be prepared. I said, have you ever thought that why we have it? No, it's not the time to think about it. Well, it's too bad.
I think that it's important to understand with monkeypox, as Dr. McCullough pointed out, we had a case last year. No one mentioned it. All eyes were on SARS-CoV-2. We had a small outbreak of monkeypox in the United States in 2003. What I think is happening now, the way I see it, is that the world contains risks and what I call fault lines. There are conflicts that are going on. There are certain risks that have long been there. If you want to inflate the risk, exaggerate the risk, make a mountain out of a molehill of the risk. I mean, we've seen how that's possible. That what I believe we've witnessed in recent years is a tremendous centralization between organs of mass media and health agencies, and again, what Dr. McCullough and I characterize as the biopharmaceutical complex. You know, if you look closely at the Gates Foundation, the World Economic Forum, the Wellcome Trust, they work very, very closely. They have an army of PR people. They have an array of grant-making networks with academic institutions throughout the world. It's a remarkably centralized, networked complex, as we call it, that I think has created something like a matrix. And we're all in the matrix now. And so I would think that just about any threat in the world could be suddenly emergent, depending on how it's presented.
But John, what's the advantage of all the telegraphing of what's going to happen? Is that lining up contracts for vaccines or drugs?
Yeah, I think that it's priming the system. Okay, you know, there's probably in that Munich Security Conference, if you look carefully through the documents and the statements, it wouldn't surprise me one darn bit if there was talk about, well, recent rainforest clearing in the Congo Basin, you know, a recent upswing of tourism or, travel flows or something. We have, identified an elevated threat or an elevated probability, and then that signals to some vaccine manufacturer to make a bunch of attenuated live virus vaccine. I mean, I wonder how that stuff lasts. What's the shelf life on that stuff? Suddenly they have 13 million doses of it, that are ready to rock and roll. I mean, I won't presume to know the mechanics of all of this, but it strikes me as very, very suspicious and should be carefully examined.
And I would be interested to know that who is financially connected to the vaccine manufacturer, because I think there is a lot of financial interest in it.
Yeah, that's a great question. Is who are the cast of characters and the financial questions? I had a clinical question. Who in the world would you vaccinate? Would you vaccinate, monkey handlers in the Congo Basin? Who in the world would you vaccinate? You can see here that they studied exposures during the hospitalization, including personnel in the Utah laboratory that handles. They had 46 contacts. And in the paper, as I recall, they looked at hundreds and hundreds of contacts. This guy came home. He went to a social gathering on July 2nd. July 8th, he flew from Lagos to Atlanta. I can tell you, he didn't pass it to a single person. So who in the world would you vaccinate? Who would accept a vaccine? I don't get this idea of 13 million doses. And, who was consulted on this? Was the Monkeypox response team? Is it everybody on this slide? Are they involved?
So glad
I mean, this just seems to be an outrage.
Let me add something here very quick about pandemic. First of all, monkeypox is not aerobic infectious disease. So it does not carry a lot of threat because it's not aerobically transmissible. Say, COVID, it transferred by air and it's aerobic. So that's the problem of it. And that's where you need to do vaccine. But in these cases, which is very few cases, it can be isolated and it can be done over after you recognize them and isolate them and quarantine them, and I think it's going to be over. So it has nothing to do with pandemic. This condition will not reach into pandemic level at all because it does not have the aerobic quality for us to be preparing of doing all this vaccine, all that stuff. So this has to do a lot with three things. Either it's ignorance of the medical people or medical field of handling this, and also it's money driven, and I think that's money is also part of it. But I think as intelligent group a network, an alternative, we can definitely squash this disinformation and squash this money-driven ignorance alarming, which has no basis.
We concluded that money is a universal desire that is easy to co-opt. But as Dr. McCullough and I get to the end of our book, you know, what we conclude is that the desire, the voracity for money is just one part of this that has been incorporated into a bigger plan, which we believe is a bigger aspiration for centralized global governance. I mean, it's long been the dream, as Dr. Peter Bregan will point out. He's written about this. As Dr. Bregan points out, you know, the dream of an empire is as old as mankind itself. There are these famous empire builders in history. We think of Alexander the Great, or the Roman Emperor Trajan, or Genghis Khan. I mean, Napoleon's desire to dominate Europe. So there are these very energetic, ambitious individuals that we see throughout history who want to create an international governance in which people in all these different jurisdictions fall under one centralized command and control apparatus. And what we believe the evidence supports is that we're currently seeing an aspiration for globalized central government, but instead of militarism being the means of acquiring this command and control, it is purported expertise and know-how for dealing with an infectious disease pandemic. So it's not, I'm a great general and I have the legions and the weapons under my command. It's, we're part of this centralized structure of pandemic response. And all of the heads of state, whether they be in Ottawa or London or Washington or Paris, they all need to take our directives and our dictates for how to respond to this, or else this mathematically modeled contagion is going to spread throughout their people, and they're going to be held responsible. So it's a centralized control mechanism by way of public health. It's very clever if you think about it. It's much more effective and efficient than military violence. I mean, rolling into a country with tanks and stuff, I mean, it's just wildly inefficient. Look at how the whole world within 3 weeks was responding in absolute lockstep. It's never have we seen such a rapid conformity of pretty much the entire human race to one centralized directive.
Yeah, I want to show, I think that's the, yeah, so I just wanted to show this slide that, you know, our Surgeon General, Vivek Murthy, put out a questionnaire, he put out a survey on where misinformation was coming from on COVID-19. And he was shocked to find out that his survey showed the primary source of misinformation was actually the federal government and the agencies, his own survey. It really backfired on it, that the practicing community has been barraged with misinformation, things that are just completely wrong about the pandemic, including, the proportion asymptomatic spread, to information on diagnostic testing, the refusal to recognize the value of natural immunity, the suppression of early treatment, no fair review of early treatment, no re-review. So there are definitive statements made, and they're never revisited. They're never, as the body of knowledge grows, our federal agencies never revisit anything. And I think there's been a clear undermining of hydroxychloroquine with falsified papers and statements. The emergency use authorization was restrictive, not expansive. And in fact, when the FDA in June of 2020 said, do not use hydroxychloroquine, they never revisited the issue as more data came out, including the meta-analysis I published on early treatment. They never revisited that. With ivermectin, our FDA said, and it tweeted out, that ivermectin is only a horse paste, a horse dewormer. And at that time, we had over 30 randomized trials that were supportive. All we need to do is see trials with a signal benefit and acceptable safety. So that was a clear misinformation propaganda strategy. And then the American Medical Association announced that they had a campaign to abolish the use of ivermectin. The AMA, they have no role in announcing campaigns to abolish the use of drugs, but it didn't stop there. We've seen a massive attempt at suppression of virucidal nasal washes, including dilute povidone iodine, dilute hydrogen peroxide, colloidal silver, clear, and other products. And there's actually even emails that have gone out through Medscape and MedPage that said that doctors using iodine nasal washes will cause iodine toxicity and patients will drink the solutions. Just ridiculous statements like that to undermine virucidal nasal washes supported by 12 clinical studies, 3 large randomized trials. I rely on virucidal nasal washes every day in patients, and it doesn't stop there. Our government now is trying to undermine the Pfizer drug Paxlovid. Now, Paxlovid, you see through MedPage and Medscape highlighting what's called a rebound. If you stop Paxlovid, there's some type of rebound in viral replication, and that there's a failed Paxlovid prevention study. And they've also worked to undermine molnupiravir. Molnupiravir, as drawn up, could be mutagenic in terms of causing mutations in somatic cells. There's been an undermining of monoclonal antibodies from the very beginning, just based on theoretical models. As the virus mutates, our federal government has withdrawn monoclonal antibodies with no clinical data whatsoever. Product after product, Lilly, Regeneron, GlaxoSmithKline, and yet despite the virus mutating, none of the vaccines have been pulled off the market, but the government was very quick to pull monoclonal antibodies off and get them out of circulation. It's made it very hard to find them. We've seen a confusing and undermining story on corticosteroids. And, one clinical trial, the recovery trial using dexamethasone 6 milligrams, somehow set into stone that was the only dose of corticosteroids to be used. Data from Fonseca and colleagues in Brazil clearly showed we could use prednisone, and it's probably better. Pierre Corey had a wonderful Senate testimony in May of 2020 outlining data supporting using solumedrol and just our conventional corticosteroids at conventional pulmonary doses for this illness, but yet somehow it was all undermined to dexamethasone 6 milligrams a day. There's been undermining of product after product after product, and the only products promoted have been remdesivir, which leads to increased mortality, and then the vaccines, which have not reduced hospitalization and death, and have their giant array of fatal and non-fatal injuries. So the only products officially promoted turn out to be harmful. Other commentary.
Hi, Dr. McCullough. Hey, we've been involved in this little escapade for a couple of years altogether, and I want to thank you and also thank FLCCC and Dr. Corey for all your pioneering work and your mentoring and leadership of our group and others. So we thank you for that. And I'll just say that on behalf of everybody. As a comment, one thing I've noticed is that being a pharmacist and also working with in medical education, that it's really important that people know the laws surrounding their license and the licenses that they work under. Because, for example, when we look at ivermectin, it's been it's pretty clearly a compoundable and legal drug, and we really haven't had a lot. There's been a lot of politics surrounding it, but really not a big regulatory pushback because it's legal to use and compound. And frankly, we used it for many years in dermatology prior to COVID-19. We've compounded with it since I think 2012 or something like that. So it's not a new drug, and it really didn't have any restrictions on it, but it was a fear campaign, right? And look at pharmacists. This drug, it shocked me that you could go to a CVS and a pharmacist would be more than happy to administer to you an unapproved drug, and in the same visit to tell you that ivermectin wasn't an approved drug, and it is. You know, they give you an unapproved a partially approved vaccine, but they wouldn't give you a fully approved drug. And that was ironic to me. So it shows me that people are listening to their employers, or they're listening to maybe their colleagues or somebody who's giving them the wrong information, but they're not looking at their own license. They're not looking at what the rules are when they're doing that. And that really surprised me. So thank you for bringing the truth out. I think the more we reveal what the rules are and what we can and can't do, and make people comfortable with that, then people will be able to practice like they want to, and like they always have. So that would just be...
Mike, to support you, the FDA in 2018 has a nice little piece on their website. Actually, I show it in my slides, and it says, it's to patients, 2018. It says, why do doctors use drugs off-label? And, the original label is the original advertising label that the drug company has negotiated with the FDA. It's what the drug company wants to claim regarding the drug. There's nothing magical about the indications. There's nothing scientific about the indications of a label. It's just what the drug company wants.
It's a legal document. But
it's an advertising. It's basically, it is a legal document indicating what the drug company wants to advertise the drug for and what the FDA says they can. That's what it is. It's a negotiation. So the indications for a drug on the label are irrelevant to clinical practice. And I've been in high-level discussions with the FDA and symposiums, and they agree because it's purely marketing. Now, what the FDA says is that what they said on their website is, why would doctors use something off-label or not along the lines of the original advertising claims of the drug company, is doctors do that, and they do it appropriately when they're fulfilling an unmet clinical need. And that's exactly what COVID-19 was. We were fulfilling an unmet clinical need using the drugs and still using the drugs that we found to be useful. And the doctors were the ones who basically created the standard of care, a standard of care through protocols. And I agree with you. I think everyone should be comforted that, as I was working with UCLA and Emory and others, FLCC, Medical College of Wisconsin, Eastern Virginia University, and the FLCC group, and South Africa, Zimbabwe, they were working together. Didier Rialt, Matthew Milan, and Dr. Lagier in Marseille, France, were working independently. Brentios in South America, Dr. Chetty in South Africa. We were all working independently, and we came up with the same conclusions, that we need drugs in combination, that no single drug is neither necessary nor sufficient to treat this illness, but we use drugs in combination. And it opened up a lot of creativity. Now, what the FDA would say, and I agree with them, is where the package label matters, where the label is not the labeling, the advertising indications that whatever the drug company wanted, but what we all should agree is on safety, that we should agree that the label applies to safety as we're using drugs in medically necessary, appropriate, off-label use. We should all agree on safety, and there, ivermectin, has a wonderful safety track record. Some say it's as safe as using acetaminophen, and I agree. Hydroxychloroquine went a little bit trickier in that the prolongation of the QT interval, which is fixed and can be anticipated, could be over the line for patients on sotalol, flecainide, or other QT prolonging drugs, or those with congenital prolonged QT syndrome. I mean, I saw a patient, last clinic session. She has prolonged QT interval congenitally. I mean, she's had VT and sudden death. I have a defibrillator in. I would not use hydroxychloroquine in her. If she got sick, I'd be very comfortable using ivermectin. The other caveat with hydroxychloroquine, and I bet Dr. Patel and others on the line have seen this, and that's G6PD deficiency in African Americans, also can occur in Asian Indians. So anybody who's had a hemolytic drug reaction to a sulfa drug, for instance, every time I prescribe, all we have to do is know the caveats of our drugs as good medicine doctors, and we're in good shape. That's the only obligation we have, is we're using our clinical judgment. And when people have told me that I don't have enough evidence to treat patients, I said, listen, I don't need definitive trials at this point in time. I simply needed to see signals of benefit in the literature that were consistent, which we did with these drugs. And then the main thing was acceptable safety. That's what I needed to fulfill my duty to treat. And I do think doctors had a duty to treat this illness from the.
I agree. Well, you brought up a very good point that was instrumental to my own thinking in this process. And again, we've been at this, I think, going on 3 years. and one of the things you brought up is that you brought up a kind of an ironic or a little bit of an ironic statement, but you were saying that you would have liked to have used the Harvard Medical School protocol or the Oxford protocol or the John Hopkins, but there wasn't one for you to use. And that was really an important point, I think, that you made, because it drove home the point to me that is exactly what was missing, was a treatment protocol, because you can't have a standard of care unless you first have a protocol. And and the protocols can vary, right? They can vary and have room. They can go this direction and that direction, and each doctor can have their own special way of viewing things. But yeah, having that protocol was real key.
Christina, can you go on mute?
Yeah, Mike Beamer, can you work on the mute there while I am going to add something very critical? Dr. Peter, you did mention that there's no drug that they can do 3 things: antiviral, anti-inflammatory, and platelets or anticoagulant. In fact, there is, which is Methylene Blue. And if you check on all of this, you will see it does have anti-inflammatory effect. It inhibits TH17, interleukin-6, and it does block the spike protein itself and preventing it from inhibiting ACE2 enzyme, which is the receptor, the docking of the virus. And it does have anticoagulant, especially with low dose. Mm-hmm. And if you look at all of these 3 mechanisms, you find it in Methylene Blue. In addition, it has a treatment for hypoxia and mitochondrial function. So we have very great experience with Methylene Blue. 10,000 scripts per month has been out, and all the patients, none of them descend into going into the hospitalization. Did not get much of attention in the public, especially with the FLSE for some reason. But us as a group, CDP, MCS, and many others, and our compounding pharmacy are doing a great job as an alternative, because ivermectin got very red flags. So we're trying to find alternative. Our mission here is just to find a way to help the patients and go around all those regulatories to find something that's still not being red flagged yet. But also, that very importantly, to know that part of failing in managing COVID-19 is also there's some part of it is ignorance, and I can say that very in a bold way, and the reason, because COVID-19 it's more of inflammatory disease, more than the damage that's causing and the death that's been result from COVID. It's because of the hyperimmune response. It's not because of the viral damage as we see in flu or other viral infection thing, where the virus replication and damage is causing the disease. But mainly the disease and the damage that's caused by this COVID is the inflammation and the immune response and the hyperimmune response, especially what we call the neutrophilic hyperimmune response or neutrophilic inflammation, which is mediated by interleukin 6 and Th17, and lack of understanding that there's three kinds of inflammation. There is lymphocytic inflammation, Th1, there is neutrophilic, there is eosinophilic. And if you go through the process of developing the vaccine in the beginning, they try to trim that spike protein in a way they get rid from all those hyperimmune part of it, the epitopes that leads to eosinophilic pneumonia, which is or eosinophilic vasculitis, which leads to polarization of the immune system to Th2. And they trimmed that. They did a very good job, according to Peter Hotis, but he forgot that he still is blocking the ACE2, and ACE2 end up with polarization of the immune system into Th17 and this hyperimmune thing. So the idea of just go ahead with steroids and giving steroid will suppress the whole three kind of inflammation, and especially if you inhibit the Th1, then you have a problem there, because then you have the space where viral replications will happen. So you cannot do that steroids, because steroids will inhibit those three inflammation. What you need is to find a drug that inhibit the Th17, the neutrophilic inflammation, the interleukin 6 mediated immune response or immune inflammation, because interleukin 6 is behind why we have hypercoagulation. It stimulates the platelets. And that is the drug, which is ivermectin, hydroxychloroquine, methylene blue. Those are the drugs has specific inhibition of Th17 without affecting the Th1. So you're not killing the virus using that. So that's why ivermectin is very successful. That's why in rosacea, for example, it's Th17 mediated inflammation. We don't have great success using steroids, because steroids cause the thinning of the skin and a lot of complication, and it makes the rosacea worse. But we have great results out of ivermectin, because rosacea is Th17 inflammatory disease. Same thing with systemic lupus. It's more of Th17. So that's why we have great success with hydroxychloroquine. So I think ignorance, add to that the money and the greed, when all of these three combined, it leads to the disaster in managing this pandemic. And what we need as a group here, as med docs and patients here and community here and people with money, is to gather those three things: the money, intelligence, and ethics. And if we combine this and we create some centers and some equivalent and power of force of goodwill, then definitely we can defeat the other side of the greed, of the lack of ethics, of the money-driven kind of health system. And that's what I encourage all the doctors here and all the team here is to think about it. We need to work together. We need to find an answer. We know the problem, Dr. I think Peter laid down all the problems, but we also need to think about the solution, the answer, and how we can reach to that step of solving this problem that we are facing here, and all this disinformation that's out there. So, Dr. Peter, Mike, can you focus on the solution now, what we need to do?
Well, I'm really glad I got you fired up about methylene blue. I knew sooner or later you were going to come out methylene blue. I was just waiting for it. I kind of threw that one out to you. I do want to ask you, though, methylene blue is this magical product. You know, our heart transplant team uses it for cardioplegia. My brother, interestingly, had a kidney stone years ago, and it was stuck. And an old-timey urologist put in an IV and gave him methylene blue, and his kidney stone passed. It is this magical drug. I've used it in cyanide poison. I had a mass cyanide poisoning event when I was in Seattle, and I remember giving a ton of methylene blue to a bunch of victims when I was there at University of Washington. But can you tell me about the contemporary use of methylene blue in COVID-19? How do you prescribe it, and what form does it come in?
Well, I think we have a pharmacist here, Dr. Mike Beamer. I'm putting together the informations, but he's the one who's making it and putting it and describing it. But what we do, we recommend as a prevention of 10 milligram a day capsule. They can also use it as a form of liquid mouthwash, because we know that the virus resides in the salivary glands, and we also put a piece of light there so to do what we call the photodynamic therapy. And where we learned the efficacy of methylene blue again is COVID, when they developed the antibodies against COVID, you remember the Griffin company, which is FDA approved, which they produced this antibodies, or they take the plasma from the patient, from recovered patients, and then they purify it, and then they give it to patient with for patient who has the infection of COVID to neutralize the virus. They cannot just take the plasma from the patient immediately and giving it, because this plasma could be have some other viral infection, HIV, maybe there's some COVID there and all that. So those companies, they use methylene blue for the dynamic therapy to sterilize the blood completely. We're using methylene blue because it will kill all the germs without affecting the proteins of the blood or the blood cells and all that stuff. And it's being FDA approved. That's a process of sterilization of the blood from all those infections. And it's a process to create all this recovered plasma from the patient who are from COVID, and which contain the antibodies, to use it for patients who are being infected, heavily infected with virus, and neutralize them. So this is the idea they came from, of using it. And then if you go to methylene blue, you will see thousands and publications higher than even ivermectin in terms of treating infection, including monkeypox. If you click on methylene blue and monkeypox, you will see it's being used for that as well. So that is but it's a good thing that it did not have that media attention, because if it did have media attention and it's being used in the beginning, or it's being advertised and FLCC and all that stuff, they will shut it down. But the beauty of it is it did not shut it down because it not got that media attention, but the efficacy is there, the result is there, the efficacy, the whole thing is there. So we start with 10 milligram, but if the patient is getting more severe, you can go up to even 100 milligram.
Wow.
I know that the Bahamas Dr. Hepburn that you visited, she's using up to 100 milligrams. So the pharmaceutical dosage is 0.5 to 2 milligram per kg. That's what's being used for cyanide poisoning. So it's within the therapeutic formula. But I like the low dose, because high dose, it can promote coagulation. And if you go there, but a low dose, it is anticoagulant. I prefer low dose myself. I don't go above 50 milligram, but Dr. Hepburn used 100 milligram. And they use it not just because of, yes, it has an antiseptic. They're using it. They used to be used as for UTI infection. It's FDA approved. That's the first drug that's being used for UTI infection, those blue, methylene blue. Again, I like to use the lower dose as much as I can, and we have very great result. And the other part of it, you know that this serotonin reuptake inhibitors, it's also being used as an FDA approved. And the reason why, because serotonin inhibit the Th17 interleukin 6, okay? And methylene blue, it also increases serotonin. It inhibits the whole serotonin, the enzyme that degrades serotonin. And that's why if you use high dose, you don't use with it serotonin SSR, because there's synergistic effect there, and it can cause serotonin syndrome. But it increases serotonin, which lines up very well with FDA-approved drug that's being used, serotonin reuptake inhibitor for COVID. Okay. And also it's been lining up with the FDA-approved drugs that used to inhibit interleukin 17, interleukin 6. There are drugs already being approved for that. And methylene blue does the same thing. It inhibits the Th17, interleukin 6, as ivermectin and hydroxychloroquine.
Dr. Hellas,
but it has many other advantages over those two other drugs.
Dr. Hellas, I'm going to have you come up for air, because I know once you get going on methylene blue, you cannot stop. And give a chance for Dr. Stefan Hartman to ask this question.
Yes, let me unmute myself. Hey, Dr. McCullough. One question, Paxlovid, I want to hear your opinion on this. I got patients asking me about it. I'm not prescribing it. Let me hear.
I started 2 patients on it today. It's really a mixed review. It's a combination of this, I believe it's called Nulfenpiravir plus ritonavir. Ritonavir is an older protease inhibitor for HIV, and the new drug is a novel, not really novel, but a repurposed kinase-like 3 inhibitor. In the randomized trial that was published in New England Journal of Medicine, it was interesting. It was given in people age 45. a couple thousand people at age 45. And it did reduce hospitalization and death, although those are very rare events in the trial. Of interest, it's the first trial where Pfizer did not allow any external doctors on the executive committee or steering committee. Every author on that paper is a Pfizer employee, somebody kind of under the Pfizer direct corporate umbrella. It's a very interesting set of authors. Once released, there's been a failed prevention trial. There's been descriptions of rebound. I've had some clinical experience with it, a couple, good experiences, and then some others not good. I found it interesting. I recently had a family member, quadruple vaxxed, who got sick with COVID in Germany, and he was nabbed off a cruise boat and put in a COVID hotel in Germany, had everything taken away from him, and was allowed to get much sicker in the COVID hotel with no treatment. And they finally put him in a hospital in Cologne, Germany. And once hospitalized, like far into the syndrome, then they gave him Paxlovid, which appeared to do nothing for him. And so now he's, has post-COVID syndrome, feels relatively wrecked by the whole event and the failure of his 4 vaccines. You heard about Kamala Harris taking Paxlovid. You saw the clip with Anderson Cooper and Bill Gates. Bill Gates allegedly took 4 vaccines, Anderson 3. They both get COVID. Likely they both took Paxlovid. Vaccine enthusiast Peter Hotez claims to have taken Paxlovid, but he tweeted out, "Boy, I don't feel too much better. There's not a very good program to treat COVID," is what he said. Very good program. And I kind of tweeted back, I said, well, go to our website or go to any one of our affiliate websites and see our protocols. We've been using them for a couple of years. It just goes to show you the oblivion of even the vaccine stakeholders when they get sick with COVID to even think about therapy, even for themselves. Astonishingly, Anderson Cooper asked Bill Gates for medical advice, and Bill Gates, not being a doctor, gave medical advice. He kind of shifted a little bit and said, I think just to be safe, we should still taking these vaccines. Even though they've had COVID, it's too late for more vaccines. They're going to go ahead and take more vaccines. You couldn't craft a more absurd type of series of events that we've seen. John, any comments?
Well, this is the psychology at the root of this. It's this commitment to this vaccine solution. The commitment was made and expressed years before SARS-CoV-2 actually arrived. And we see as early as March the 16th, 2020, they've already got the Moderna messenger RNA vaccine in testing. And what we have observed in this is it's like we have this massive plan and financing and a network, and it's all ready to launch like a massive train pulling out of a station. And it's the vaccine train. And this was from the outset of the pandemic, from the very beginning. This is going to be our response. There's a massive commitment to it. And once all of this gets underway, as it becomes apparent that it doesn't work, just to be blunt, it doesn't prevent infection or transmission, there is, I would say, naturally, what we know about human nature, naturally there is going to be a tremendous reluctance to say, it didn't work out. We were wrong. We misread the situation, and now we're going to have to revise and alter our course. I happen to think there will never be an admission from the chief stakeholders in this that they were wrong. But the world should recognize that this is now becoming commonplace. So these young fellows come into the country in 2001. The FBI, as we now know from these redacted pages of the Joint Congressional investigative report of September the 11th. We now know that the hijackers were under observation. They were in the country on expired visas. The FBI was observing them and was writing reports from the field. Nevertheless, they still pulled off September the 11th. This sets in motion this massive foreign policy machinery, which invades Afghanistan and then invades Iraq, and the Bush doctrine of reshaping the nation building in the Middle East. And what's remarkable about it is, we get to the end of 2021 and it's just like, well, it didn't work out. We're pulling out of Afghanistan in haste and chaos, leaving it to the Taliban. So it would seem that all of those guys killed and maimed, all of the money that was spent on the occupation, in the end, it's like, well, it didn't work out. But there was no real reckoning with this. How did this happen? Why did it happen? One of the things that we examine is when you get to this very high level, there's a lack of accountability and a responsibility, which is very, very discouraging. I think that all we can do is what we're doing here, what Dr. McCullough has done, what I have joined him in our endeavor to write a book, is try to bring it to the attention of our citizenry that they are constantly being propagandized for these massive endeavors, whether it's nation building or public health or pandemic response. We're constantly being subjected to these big agendas and programs. And I think the first step is just people understanding that it would seem our governments no longer represent our interests. I mean, maybe they never did. Maybe it's always just a matter of degree. But we seem to be living in a time where government is just not accountable to its citizenry.
It's certainly, government cannot be viewed as looking out for our best health interests right now, right? The suppression of early treatment and now railroading this disastrous vaccine program. A lot of great comments have come up in the portal. Maybe Dr. Halesa can come back on and help address some of these. I saw a great comment about chlorine dioxide. Chlorine dioxide, the method of sterilizing stream water when camping, that sterilized water has also been used medicinally in a variety of applications, SARS-CoV-2, but a variety. Anybody here on the line, this is a very creative group clinically. Anybody want to bubble up a comment about chlorine dioxide?
Dr. McCullough, this is Dr. Cruz. Many of my patients have reported that it's very effective, but I've also heard that any physician promoting chlorine dioxide has a great chance of getting their clinic closed and their license pulled. So I, quietly endorse it. It can be given IV quite safely, orally, nasally, nebulized, extremely cheap, and entire countries like Africa are having dramatic benefits from it. But I would be very afraid to, promote that openly. I wanted to learn again when you don't like hydroxychloroquine, what clinical situations. And a second follow-up that's even more pressing, Dr. Sylvia said that the WHO treaty between the U.S. and the WHO has already been signed, which I missed. And what are your thoughts on, how are we going to defend ourselves as a country against the WHO? Because when people ask, is there malevolence and evil? I mean, I think it's more than obvious. Government, big pharma are in bed with each other, and there's no limit to the crimes against humanity for profit. And I know for some, even on this group, that seems like an exaggeration. But when you read Robert Kennedy's book, when you read a condensed article by Dr. Blaylock, a neurosurgeon, It's like, and there's a history of bad acting, with the Vioxx drug, with the opioid drugs. And now, all three vaccines are ineffective. And to me, anybody who takes it is playing Russian roulette. I mean, I've seen young people get serious cases of myocarditis. A friend of mine's son, he's 24. I've seen a lot of stroke, heart attack, and blood clots. And I mean, I'm horrified, and I am amazed at how many of our colleagues, including my own sister, who's a family doctor, are just drinking the Kool-Aid. And you can't even have a rational discussion. But I know I'm getting long. Dr. Halas has been training me. What are we going to do with this WHO treaty? And how are, the smallpox thing is just another attempt in my mind to see how many sheep we can terrify into getting another unnecessary vaccine. And how are we going to defend ourselves against these ongoing attacks on our citizens who are being manipulated by fear?
Dr. Cruz, I can tell you in your wonderful log cabin that you're staying in now, you really got fired up with the I'm going to let John Leake address WHO in the second half of that, and I'll pick up on the medical part in the first half.
Okay.
These international treaties are only as strong as the will of the signatory to execute it. And so, I mean, I think the media, both sides of the media have perhaps not really addressed the precise mechanics of this. I mean, it's if the United States entered into an international treaty with the WHO, I mean, we could abrogate the treaty if we felt like the WHO is overreaching or trying to institute policies that aren't in the interest of our citizenry. And I mean, we could be perhaps sued in international court or something. But I don't think for a powerful nation like the United States, that's really such a frightening proposition unto itself. What the WHO treaty to me is frightening is it's just giving cover to unstated actors and interests. For some reason, the Biden administration is playing along with this. But to me, that this looks like you are dressing up, you're giving cover or a front framework for actors who are not declared, who are not stated. And my concern is it's this biopharmaceutical complex of which the WHO is a sort of a front organization. I think it's very useful to look at the literature and the history of organized crime. The organized crime bosses, they don't come out and declare themselves. They usually have front organizations. They have bankers and judicial organs that are fronting them. And that's what I see happening here. So the WHO seems to have a very close relationship with the Bill and Melinda Gates Foundation. For good reason. The Bill and Melinda Gates Foundation is the second largest funder. The first largest funder is Germany. I think that you also have to examine the role of Switzerland in all of this. Switzerland, for centuries, has played this role in European affairs where they're this neutral territory and neutral region of banking that we now know there's a huge pharmaceutical industry there. And Switzerland seems to have played a very large role in this biopharmaceutical complex. It's where the World Health the World Health Organization convenes in Geneva, but you also have the World Economic Forum. So I think this is what needs to be examined. Who are these actors? Who are their financing? What is their relationship with national governments and national treasuries? That will show us who's behind this. I think Tedros is just a sort of a puppet.
I just want to quickly address Raphael's questions. Hydroxychloroquine, I would stay away from in congenital long QT syndrome where there's been significant arrhythmias. In patients on other significant QT prolonging drugs, I think the big ones out there are sotalol and flecainide are the big ones. Those are the only relative concerns. For ivermectin, I've been a little bit leery in patients with uncontrolled epilepsy because it may lower the seizure threshold, and then in patients who have advanced liver failure. I've never had somebody with ascites or something like that where I've tried to use ivermectin. I think those are the only other caveats. Let's bring up Margaret Christensen. Dr. Christensen, you had a comment, your hand up?
Yeah, I was just going to comment regarding the chlorine dioxide. Again, I'll just second the comments that we can't use it as physicians. I do have a very good friend of mine who's a doctor of clinical nutrition. She's also a pharmacist who has used it on a number of her patients and clients and family members via enema, again, via nebulization, orally dilute. You have to be, a little mindful of it. But she said within a couple of hours, people have a Herx response and, feel really crappy and then immediately get better. I mean, she was her first N of one with it, but she's treated a number of folks with it and suggests that we all have some for whatever might be unfolding as we move forward.
Good comment. It involves basically using the most common oral application is using distilled water or sterile water. And then for 1 liter, it would take 23 drops of the base mineral and then 23 drops of the activator. If you got it down to some reasonable intake, let's say 8 to 12 ounces, that would be about 5 drops of each. Those are common applications. If you look in the literature, it's amazing the supportive literature for chlorine dioxide.
Really?
Although I did go over to the Mayo Clinic website and a few other general websites, and they have the strongest admonishments for using chlorine dioxide, as if the world would blow up if anybody used this. And I do find that strange because it's an accepted way of sterilizing water when you're out camping, and why the Mayo Clinic would have such incredible warnings against the use of a water purifier. So, okay, where are we at in terms of more questions? We've been at this for about 2 hours, you guys. That's about my limit. There's a question.
Can we talk about the solution here, the answer, how we can solve this problem? Do we have to punish people who are make those people accountable? Are we looking for people who have the money, like Elon Musk? He's now becoming Republican, and he is a billionaire who will be supporting yourself, Dr. McCullough, because he's more of common sense and looking for changing or reaching out to the politicians and have some lobbies there, or reforming clinics that will have equivalent to Mayo Clinic, but setting up really protocols and managing things based on evidence-based and based on the interests of the patients. What is your think? What is the solution here?
I think you're on the right track. The most common thing I'm hearing now is just, having alternative systems. You're building an incredible one that's so creative and I think imaginative with no boundaries in terms of what you're trying to do. I think that's probably going to be it. The patients will vote with their wallet. And I think patients have lost their trust in the biopharmaceutical complex. They want to get back to good old trusting relationships with doctors. They're willing to pay cash. The higher end expensive stuff, can be built through the insurance, but they want a doctor who's, I think, largely the type of doctors on this call. Joel Peterson's got a heart and a hand up. Dr. Peterson, big beard. What do you got for us?
I volunteer with Dr. Clearfield, and I'm not a doctor. I'm an advocate and an activist for you doctors and for military, for vets, second and third responders. If I was to create a private membership association like Joel Salatin, would you guys be able to send your patients to me so that I could get this type of medicine or this type of chlorine dioxide and ivermectin and hydroxychloroquine to them? I believe I legally could.
Again, these are the alternatives. On the McCullough report, I interviewed a nurse who had to stay anonymous for what she was doing. I interviewed her actually in the first year of the pandemic. A wonderful lady. She had actually felt so disturbed about the suppression of early treatment. She bought ivermectin and hydroxychloroquine and all the other drugs. She bought them in bulk overseas. And she loaded up her van with all the different medicines. She knew the protocol. And she actually went on her own and she treated senior citizens of Northern Georgia on her own. She's not a doctor, no doctor's license. She just treated patients and saved their lives. She felt it was her calling to do this, a mother of 6, and she spent her time during the day while her kids were studying, trying to save patients. These stories, and you know, what this crisis has done is it's brought us together in so many different ways. And I like your idea, Joel, that you know what, medical licenses may become irrelevant in this new reality, right? There may be something else that comes about. There's a clear interest, and I'm feeling the sentiment of my patients. There's a clear interest of getting away from prescription medicinal drugs and a much bigger interest in naturopathic, homeopathic, Eastern Asia. I recently had on the McCullough report Dr. Adipole from Thailand, and he let me know that a lot of the different types of Eastern Asian remedies that they're using now, he believes successfully to ease people through COVID, are the same ones they used to ease people through the Spanish flu many decades ago. So I thought that was interesting. Dr. Halesa, can you give us some guidance? Maybe are we going to wrap it up, or I see a lot more.
Well, you know, I have no problem keeping the room going if there is benefit and people are learning and if there's new ideas, new perspective, because we really need to work very hard in coming up with answer to all those problems. And I think I need you to even focus more on that and how we can do it. What's the next step? Because we got the problems. Okay, we know we have the problem. What will be the next step? What we will do? I think those are things we need to focus on so we can move forward with agenda.
Well, listen, I'm going to go ahead and sign off. I imagine John will sign off too, because I've got to answer some patient phone calls. I'm really well behind, but go ahead and keep it open. And thank you so much for having us on. Remember the book, it's on Amazon. The book, Courage to Face COVID-19, Preventing Hospitalization and Death While Battling the Biopharmaceutical Complex. Most of you, are in the book. Whether you're in it by name or in it by spirit, you're in the book and buy it. We think through using a narrative, telling a story, we may be able to break through some people where it hasn't become apparent to them what's going on by just showing data. As many of you know, I'm a frequent contributor on Fox News, all the major news stations. I wonder how much we're actually getting through to patients. And so John and I are very passionate about, a book, a soft cover book that's readily, it's available, it's affordable. Just can we get the information in a way that's digestible through a narrative? John, any final words?
I concur with Dr. McCullough. We've endeavored to tell this in the form of a story that I think the general public can readily understand. I think the general public will find it an engrossing story. It will engage their emotions. So we worked real hard on it. Dr. McCullough has really, on top of all of his other work, has been there with me in the trenches to produce the book. So I hope you'll tell all your friends about it. Pass the link around. The website, couragetofacecovid.com. It has a portal to buy the book. Pass it around to your friends. We would be grateful, and we think they would enjoy the book.
Thank you, John, and thank you, Dr. McCullough. We'll see you guys next time, and we will be sure and support your book. We are very grateful for you guys and the work you do and the leadership and the mentorship that you provide to our group. Thank you very much, and God bless you guys.
Thank you very much, Dr. McCullough. Thank you very much.
Thank you.
Yep.
Thank you.
So before we close the meeting, I want to thank everybody for being here. If anybody of you are looking for COVID protocol therapies without any risks or problems, you're welcome to give me a call. We ship to all 50 states through our network. We have a direct patient portal. We have all the medications available that are used in any of the protocols. We don't pick and choose like what protocol. We have FLCCC's protocol. We have Colossus. We have others. And, all of those things are available to your patients. Next day ship, you can get people what they need quickly and efficiently and reasonably priced. Ivermectin is down to $3. Okay. So, everybody can afford it if they need it. But anyway, if anybody has any further questions, I'll let Dr. Halasa take back over and we can go from there. Well, we may be done.
Mike, can I?
Anybody got a question? Yes, please.
I did ask in the chat, but so we in Australia it's illegal to get ivermectin, and I've tried to get a few friends from Washington State and other states in America to see if they can send me some presents in boxes, and but we kind of sense that our customs will probably find them one way or another. So how could we? Do you know of any other doctors that are bringing it into Australia sort of detected?
Yeah, I can tell you a little bit about that. Now, I can't speak specifically for Australia, but I've been spoken to about this subject